Hello and welcome to today's Clinical Distance Learning Series webinar. I'm Christopher Balanci and I'm leading this initiative on behalf of the Substance Abuse and Mental Health Services Administration, Center for Mental Health Services, Child, Adolescent, and Family Branch, or as Gary Blau would say, the branch, along with the TA network. We're very excited to offer this first-of-its-kind training series for System of Care grantees, and thank you for participating. The purpose of the clinical series is to identify and provide technical assistance around the latest innovations in child and adolescent clinical interventions. Our goal is that the series will appeal to a broad audience, including youth, families, clinicians, and administrators, allowing all interested stakeholders in your community to gain convenient access to the latest information on best practices in child and adolescent behavioral health care. The TA Network's clinical track will be presenting a three-part series focusing on youth with co-occurring disorders, those youth with both mental health and substance abuse challenges. The series will be accompanied by 5 briefs covering the topics of prevalence, screening, assessment and diagnosis, integrated treatment and outcomes, and program implementation issues. So stay tuned for information on how to access those briefs. This series is a collaboration with the Center for Innovative Practices at the Beacon Center for Violence Prevention Research and Education at the Jack, Joseph, and Morton Mandel School for Applied Social Sciences at Case Western Reserve University. The intent of the series is to increase the awareness of this underserved population and identify clinical tools for both assessment and treatment, with particular emphasis on integrated treatment. The series will also address the challenges and opportunities at the implementation level. So with that, I'm going to introduce Patrick Cannery from the Beacon Center, who will be introducing today's speaker.
Thanks, Christopher. Appreciate that. We're really honored here at the Center for Innovative Practices at CASE to collaborate for this first go-around in the clinical series for System of Care partners. The population we're going to talk about today, kids with co-occurring disorders of mental health and substance use, has really become a passion here at CIP over the last several years. So we're particularly thrilled to share this time with all of you in sharing with you a little bit about what we've learned. And I think through the office hours process, I think that's a follow-up to this webinar, to learn also from you what your experiences are, both the good and the challenge, in working with kids and families that are involved with co-occurring disorders. I just wanted to say a few things about the role of the center here at CASE. So we are a statewide center of excellence here at Case Western. We were created about a little over a decade ago as part of a statewide initiative to promote the dissemination and the use of evidence-based practices across the state of Ohio. So our particular center focuses on youth and families, and our particular area of expertise, we think and we hope, is really on intensive home and community-based services. So part of our role here is also as a network partner for the dissemination of MST, multisystemic therapy. And we are currently talking with our friends at FFT to help disseminate that model further in our state. In addition to that, we do a lot of training and consultation on intensive home-based treatment, including the development of a treatment model that we're piloting here called Integrated Co-occurring Treatment, ICT. It's an example of an intensive in-home services for kids with co-occurring disorders. And as Christopher mentioned, later in the series on, I believe it's under the topic of treatments that work, we'll be sharing a little bit more about that model. So with that, I would like to introduce Michael Fox. Michael is a research associate here at CIP at CASE and comes to us with a wealth of experience in the world of substance abuse treatment and behavioral health. He's a research associate here and holds credentials in professional clinical counselor and licensed chemical dependency counselor, and does the vast majority of our community training of providers and provides consultation for our integrated co-occurring treatment model. So it's my pleasure to introduce Mike Fox. who's going to share with you today some information on prevalence, screening, and assessment.
Thank you, Patrick. Good afternoon, everybody, and or good morning, depending on where you're listening. I should mention that Case Western is in Cleveland, Ohio, just in case you didn't know. So when Patrick talks about disseminating across our state, he's talking about Ohio. And I should mention, in case it's not the case where you are, it is a really nice day in Cleveland here in November. So the sun is shining, and it's pretty warm outside. So we are sitting in a room with great big windows, so I can enjoy the sunshine a little bit, as hopefully I don't put you to sleep while you are doing emails beside watching the webinar. So as introduction here with this slide, we are going to cover prevalence of both drug and alcohol use and mental health issues with youth, and then we are going to wrap up talking about screening and assessment methods to be used, that can be used, and ways that they can be used with youth. And I should mention, I will probably use youth and kids interchangeably, and I don't think that there is any technical description for either one. And when I say kids, I am referring generally to teenagers, the 13 to 18-year-old population. It is typically who I work with and who our center typically works with. The thing to consider is a lot of what we talk about can unfortunately also be applied a little bit younger than 13. I was just in consultation with a couple of different programs this morning that do home-based co-occurring work with youth, and several of brand new clients introduced today were 11 and 12 years old. So, and they have to be co-occurring to be in the programs that I was talking to. So things can unfortunately start pretty early. On the other end, past 18, certainly quite a bit of what we talk about goes past 18, and we're going to talk about some developmental stuff in just a moment as a way of introduction. And I think a lot of what we talk about can extend well beyond 18, especially if the 19, 20-year-old is living at home, living with his or her parent or parents, and living in that situation. And what's going on developmentally would certainly apply past that point. So I would like to point out with this slide, I did not select that color of green. I had a different color, and then when I applied the background color, that color came up. So this slide I use quite a bit because there's a lot of different ways to think about what's going on developmentally with the age range that we're talking about. Some different perspectives. They wrap around this age range, but they really interweave quite well, especially when we think about the brain development at this stage, as it we can. That's more of a biological approach, but it weaves in very well with a psychoanalytic description with Erickson's psychosocial model of development. If you think about what's going on, the crisis, something versus something else at that stage. If you remember your Erickson, and at the stage that we're talking about here with teenagers, we are talking about identity versus role confusion. And that fits in pretty well with what we know currently and what we're learning about brain development, especially with that prefrontal cortex development that's going on, with the solidification of, what the teenager is going to look like as an adult. That personality is really settling in. They're practicing different things, and I think those things fit very well. When we're talking about both mental health and substance use issues, certainly family and genetics play a very large role, and we're not going to get into that today. It's something that we talk about, consider quite a bit, though, when we are expanding a case looking at co-occurring youth. Sexual maturation, the pressures associated with that. So it's not just struggling with making less impulsive decisions with the prefrontal cortex and deciding who you're going to be when you grow up, with that personality development settling in on top of everything else. Then the sexual maturation is taking place, and motivations are certainly changing. So there's quite a bit going on. And then the last one that I have identified here, and I'm sure that there's a lot more that we could consider, just these are ones that we talk about quite a bit. If you think to your Piaget in terms of cognitive development, also fits in really well with what's going on with the prefrontal cortex development piece. And I apologize for saying so many times. If somebody wants to keep count, you can log that into the chat, and for every 10, I'll answer a free question. But with Piaget, we think about the youth moving from that concrete operation stage into a more formal operation stage. I think Piaget may have been a little bit ambitious in terms of identifying at what age that actually occurs. But for those of you who work with teenagers, you can really see the way that they start to be able to expand their ability to think in the abstract, or conversely, that they're not really able to begin to think in the abstract like you would hope that they would. So all of these things developmentally that we really want to consider in terms of how are mental health issues impacting that developmental course, and then just as, or even more importantly, how are drug and alcohol use impacting that developmental course. With that in mind, for the one circle on that previous slide that stood out in the different color, that prefrontal cortex development, thinking about what is going on with that part of brain development, with the prefrontal cortex being the last piece of our brain to develop, and we know that can go on until we're almost 25, 26 years old. So it goes on for a lot longer than we used to think that brain development was going on. And what is going on with that prefrontal cortex piece, it is, they call it or refer to it or compare it to, executive management functioning, that comparison, that pro versus con decision making. I like this description, this triadic model that talks about approach and avoidance decisions, and how that is really starting to be practiced in the way that it starts to solidify through the teenage years. And during these teenage years, we can think about considering the amygdala and the striatum, with the amygdala being more of the avoidance side, the more conditioned fear side, the striatum more of the motivation to move towards, the more approach side of things. And a lot of times when I think of teenagers, I think about them being, all approach side and not avoidance side at all. That's probably not the right way to think about it, although it might be the practical way that it plays out. But in truth, both of these sides, both the approach side and the avoidance side, are really turned up to volumes that they are never going to be seen again. It's related to, you've got more neurons than you need, and then through practice, they are pruned down to what is eventually going to be used. So both of these sides are turned on to full volume, both the approach and the avoidance side. But with teenagers, you can guess which side wins out. It is the approach side very often. That's the way that it's supposed to work. Teenagers are supposed to be more impulsive. They are supposed to be somewhat rebellious, supposed to make decisions that aren't necessarily in the safest direction. But they are also supposed to learn to weigh those decisions to be a little bit more protective. Now, when you throw in to the mix mental health issues that are starting to settle in during this age, and then very especially when you throw in drugs and alcohol into this mix, it can really start to wire things in more of an approach, a higher level of risk-taking than would be there without those influences. And that, like I said, that's probably especially true with drugs and alcohol, that eventually that pruning that's taken place may wire our adolescent as they move into transition age and then into adulthood, may strengthen the high-risk behaviors into adulthood. And those are ones that are going to be difficult to change as they move into adulthood. So when we're working with youth who are moving into the early stages of drug and alcohol use, and they're kind of growing into their mental health disorders, it is a really good time for us to be involved as clinicians and as policymakers to help influence some change at that level. So not necessarily have anything to do with prevalence or with screening and assessment stuff, but just leading up to that and speaking to the importance of really paying attention to prevalence issues. So that being said, moving into the prevalence and statistics kind of stuff, and I know that looking at numbers can not be the most exciting direction to go, hence the picture of somebody yawning, which looks nothing like me. It doesn't look like Patrick. So when we take a look at this stuff, the numbers can be tedious, and they can certainly be overwhelming because there's such such large numbers out there. Why do we really want to take the time to grasp this? Well, in thinking about how important it is to intervene at this stage and the long-lasting changes that we can help youth and their families to undertake, so that hopefully they will be a little bit better protected as they move into adulthood. Understanding what are the current trends, what's working, what's not working, what has been effective, what is not so effective. It really helps us make those decisions as we're looking at either setting policy or selecting treatment, trying to match treatment to an individual youth. So it does this at a lot of different levels. It really speaks to the importance that we understand this, at least from a broader perspective. With that in mind, to mention, only about 10% of adolescents who need treatment for substance use actually receive it. Only about 20% of adolescents who need treatment for mental health disorders receive it. And only about 2% of people who need treatment for co-occurring disorders actually receive evidence-based integrated treatment. Ideally, I was looking for one that said 30% there at the bottom, so we could go 10, 20, 30%. But this 2% stands out for a couple of reasons. One, and first maybe a little bit more tongue-in-cheek, they say with statistics, there's lies, there's damn lies, and then there's statistics. So you can say really just about anything you want with statistics. I guess that really relates well to today being election day. That ties in pretty well. But with this 2%, it's just paying attention to the way it's worded. Only about 2% of people who need treatment for co-occurring disorders actually receive evidence-based integrated treatment. Now, that does not mean that only 10% of kids who need substance use treatment get it, 20% for mental health get it, but only 2% that have both going on get it. That's not what that one is saying. That one says only about 2% of people who need both, and they need it in an integrated fashion, and that's something that we will talk about here coming up. That integration, when you have both the mental health and the substance use going on at the same time, paying attention to that and addressing that in an integrated fashion. So of that 2%, it's not saying that there's 98% out there who aren't getting any treatment at all. It's just saying that it is so hard to find good integrated treatment that's delivered in an evidence-based manner. It's just, we're just now starting to recognize how important that is and how useful that is to address it in an integrated fashion. When we take a look at the prevalence here, there are three really big sources that we draw quite a bit of our information from. The first one that I want to mention here is Monitoring the Future study, usually abbreviated the MTF. It is conducted yearly, sponsored by the National Institute on Drug Abuse. It measures drug, alcohol, and tobacco use among 8th, 10th, and 12th grade students. Students is italicized there to point out that it is students. This is conducted in the school, and we'll talk about why that stands out here in just a second. And it asks about average use levels, perceived risk to drugs, the disapproval of drugs, the perceived availability to getting drugs, alcohol and tobacco, and all of that is really useful information. So it doesn't just ask about, hey, have you ever tried or have you ever used? It also asks, how dangerous do you think this drug is? How easy do you think it is to get? So this is really useful information when we come to predicting trends. I would probably be remiss not to mention here as a lifelong Ohio State fan that this study is it is put together at University of Michigan, and so I really feel like I should have something disparaging to say about it as an Ohio State fan. But unfortunately, it is so well done and it is so useful that I think that this must be an anomaly in Ann Arbor, and I really like it and find it useful. The second one to mention is the Youth Risk Behavior Surveillance, the YRBS. This is conducted by the CDC. It gathers national, state, and local surveys conducted every 2 years, and this one is also conducted in the schools, just like the MTF is. And so the thing to consider with the MTF and the YRBS is they gain information on kids who showed up for school that day. And with some of the kids that we are talking about, that we study, that we work with, they can be on the higher end of need. And one of those things that make them stand out as being on the higher end is that they are not going to school. So a lot of times when a youth has both a mental health and a substance use issue, there's a lot of family issues going on, and one of the first things to suffer then is school attendance, or behavior problems can keep them out of the schools. So when we consider some of the prevalence issues, when we talk about these first two studies, these are school-based, and so they may underreport just a little bit some of the higher-end kids. Just to wrap this one up, monitor priority health risk behaviors. This is coming from the CDC, so this is health risk behavior. This is what risks death, including unintentional injuries and violence, tobacco, alcohol, and other drug use. Sexual behaviors that contribute to unintended pregnancy and STDs, including HIV. Unhealthy dietary behaviors and physical inactivity. So, you know what? And I forgot to mention, I see that somebody has typed in a question, and I should have mentioned this in the beginning, and really all of us failed to do so. If I have time at the end, I will try to get to some questions. I don't know if that's going to happen or not. But we have scheduled on Monday, which is a week from yesterday, which would make it, November 10th, and I believe it is also at 2 o'clock. And I should have that information right in front of me, and I don't. But there is a follow-up call-in session where you can call in, and we will have an open discussion regarding the questions that anybody may have. Oh, wait a minute. Just handed to me, hot off the presses. Yes, that will be November 10th from 2 to 3 o'clock. They are calling it office hours. You can email any questions to the institute at ssw.umaryland.edu. So if you have any questions that I don't get to today, and I'm not sure that I'm going to, I hope that you'll be able to participate next week for that call-in session. The last source of information that we use quite a bit, and there's more, but there's these three biggies, is the National Survey on Drug Use and Health. This one used to be called the Householder Survey, and for good reason, because it's conducted in the house. So the first two are conducted in the schools. This one's conducted in the house. This is conducted by SAMHSA. They send out researchers to people's homes. They go around approximately 70,000 randomly selected individuals 12 and older. So this is not just focused on youth like the first two are, but this is 12 and older, and they have a subset that takes a look at just the youth. provides national and state level estimates on the use of tobacco products, alcohol, illicit drugs, including, and everybody is really paying attention now to the misuse of prescription drugs in this particular population, and also mental health in the U.S. So those are the three big places where we get information regarding prevalence issues. So, and like I said, there's more, but these are excellent. They are nice in that they have been going on for years and years, and you can really take a look at trends from one year or every other year to the next. And while all three studies are conducted in slightly different ways, and the ages can be just a little bit different, the numbers that they come up with, like the prevalence of kids who smoked marijuana in the last 30 days, you'll get a range on that between the three of them. The nice thing is that when you take a look at the trends, is use going up, is it going down, staying the same? The trends of all three studies tend to go in the same direction. So they come up with slightly different prevalence numbers, and that can have some relation to do with where the study's conducted. Is it conducted in the school, is it conducted in the home? And there can be pros and cons of both of those. So those are the three sources of information that most of this has been drawn from. And I see that Christopher has typed in, because I didn't have it handy, and I appreciate that. Thank you, Christopher. Where to register for the call-in next Monday. So, all right. So into some numbers. This is a time when I expect you all to pay very close attention and not checking your email. That's a joke. All right, so prevalence. Trends of any illicit drug use. A little star there. This does not include alcohol, tobacco, or inhalants. This is, it's interesting that, two of the studies specifically take a look at just adolescents, but they stick to using definitions used on the adult side. So, really anybody under the age of 18, every single psychoactive drug that we talk about, is an illicit drug. You can't buy cigarettes, you can't buy alcohol, that shouldn't be included, but it is not included in any of those studies when they talk about illicit drugs. They are talking about basically marijuana on up. So, trends of any illicit drug use, have you ever tried? So this would be, lifetime by the senior year of high school. You can see in 1981, we hit the high point, really no pun intended there, at 66%, meaning that by the time a student had graduated from high school, 66% of them had tried something beyond just alcohol, cigarettes, or inhalants. And I don't mean to say just with that, but 2/3. 1992, just a decade later, we got to the low point at 41%, and now here we are with last year being the last year studied at 50%. So half of all kids who graduate from high school, and again, those are ones who graduate from high school, so the numbers could be just a little bit higher. Half of all kids who make it to their senior year in high school have tried something beyond cigarettes and alcohol. Any illicit drug in the previous year. So the last slide we looked at was, by their senior year, have they ever tried anything? This one is maybe a little bit more useful to us, saying, so in the last year, how many students reported use of any kind? So 40% of all high school seniors reported use of some kind in the last year. 28% of all 8th, 10th, and 12th graders combined reported use. And then in the last 30 days, so over the last month, 26% of high school seniors reported that they had used something, and 10% of all high school students reported that they had used something. When we take a look at that 28%, that would be students, and this one is from the Monitoring the Future study because it's looking at the 8th, 10th, and 12th graders. 28% reported in the last year they had used something. This drops to 11% when marijuana is taken out of the equation, which is the single biggest psychoactive drug that is used. And again, this is illicit drug use, so it's not counting alcohol or cigarettes. So it falls to 11%. But that means, on the other side, I mean, we can say falls, but that still means that over 1 in 10 of all 8th, 10th, and 12th graders in the last year have used a substance besides cigarettes, alcohol, or marijuana. So depending on how you look at it, that's either good or bad. I tend to look at that as bad. So in the previous 30 days, then 26% seniors reported some kind of use. 10% of all high school students reported some kind of use in the last, just in the last 30 days. That one is taken from one of the more conservative ones. It goes up as high as 23% in the last 30 days in some of the studies, which is pretty high combined for all high school students. So anywhere from, there's always that range, anywhere from 10 to, so let's say about 20% of all high school students have used in the last month. So that's 1 in 5. You walk into any classroom and, 1 in 5 of those students have used something in the last month. And when we say in the last 30 days, we think about that, we talk about that as being, current use. Not going to talk about too many real specific drugs here, at least not from the perspective of the dangers associated with it too much. Mentioned binge drinking and the dangers associated with that, but one that really stands out are the inhalants. And I heard when I was a kid, which was a really long time ago, and I don't know if any of you have heard it. If you have, raise your hand. That every time you take a drink of alcohol, it kills a few brain cells. But it doesn't matter because we have so many brain cells that, if you're a normal drinker, it really doesn't do that much damage. Well, it turns out if you've ever heard that, that's not true. Every drink of alcohol does not kill brain cells. As a matter of fact, you have to be a very serious drinker and do it for a long time before it starts impacting the brain in that way. The only drug, the only psychoactive drug that has the potential to very quickly kill brain cells are the inhalants. And so, I mean, this stands out as a special category that we need to pay attention to. And a lot of times this is one that we are going to see used by the younger set of this population that we're talking about. Whether it's more attractive to the younger set or it's more available, which is the more likely thing. If you're in 7th, 8th, 9th grade, it is easier to get a hold of a keyboard duster, which is the single most common thing that they use to inhale. It's just a lot easier to get a hold of that than it is marijuana or alcohol. So, and of all the ones out there, this is potentially the most dangerous. You could make arguments for others, but I'm gonna make the argument that this one is the most dangerous just because of what it can do. So inhalant use carries all the same concerns as the other substances, plus, this is the one that can actually kill brain cells. Inhalant abuse has been decreasing for years, which is the good news, but it remains a significant concern, especially for the younger adolescents. Nearly 9% of all high school students reported trying an inhalant at least once in their lifetime. So by the time they get to 12th grade, at least 9%, almost 1 in 5, have tried an inhalant. Just over 5% of 8th graders reported using an inhalant last year. So, as compared to some of the other ones, that's a lower number, but that is still unacceptably high just because of the damage that it can do. So, and if you compare 8th grade to 12th grade, just 2.5% of high school seniors reported using an inhalant during that period. So twice as many 8th graders are using that particular type of drug. No, a particular type, it's a class. So many different things can be used as inhalants. So if it evaporates quickly, a lot of times that can be used as an inhalant. Let's move on to alcohol. Alcohol use by adolescents has been declining for years. Again, the good news. And it is currently at historically low levels. Also good news. Despite this, alcohol is the most commonly used substance by adolescents. It is one I know, from my perspective, as a clinician working with teenagers, it's easy to overlook just because it is so ubiquitous. for those of you who work with teenagers in drug and alcohol settings, a lot of times it seems like you can ask them, why are you here? Well, I'm here for drugs, and why? Well, I'm on probation and I smoke marijuana, and I keep getting popped on that. I love marijuana. God gave it to us. It grows out of the earth. It's great. Do you drink? Oh, a little bit. I don't like it. It's not really a problem, is what they'll say. When you really interview them and get more information, you find out that alcohol is ever present. It is always there, and certainly it impacts the way they make decisions very, very quickly. And it is the one that is used the most commonly. So I'm sure absolutely none of you would do as I have done and kind of accidentally overlook the importance of that. But just learn from my mistakes, and don't overlook alcohol. In their lifetime, between 44 and 66% of youth report having tried alcohol at least once. That's I think a statistic that's pretty easy to believe. During the last 30 days, keep in mind that we are at historically low levels of use here. So during the last 30 days, what would be considered, current use, 24 to 35% of youth reported drinking alcohol. So a quarter and above in the last 30 days of youth. And so when we combine that, when we say youth, we're combining that, looking at basically all high school students. 20% of all high school students reported binge drinking. 20%, and again, this is at the lowest levels they have been in a really long time. 1 in 5 drinking 5 or more drinks on a single occasion, and this is another occasion where it's interesting that these studies are all really well done, but they use adult definitions when measuring drug and alcohol use in youth, and the definition for binge drinking for an adult male is drinking 5 or more drinks on a single occasion. And for adult females, it's drinking 4 or more drinks on a single occasion. But they use the adult male definition, which maybe doesn't fit too well with our youth. They don't have as much experience drinking. Physically, they are not as large, and certainly there are all those developmental issues that are going on. So 5 or more drinks on a single occasion in the last 30 days by 20% of all of our high school students. And again, those are the ones who showed up for school that day. 6% of all high school students reported extreme binge drinking, which is drinking 10 or more drinks on a single occasion. And that one, I think, was actually in the last 2 weeks, which is really the definition of binge drinking. But some of them measure it in 30 days, some of them measure it in the last 2 weeks. And I think this last one was done over the last 2 weeks. 6% of all kids in high school reported that they had engaged in extreme binge drinking in the last, let's say, 2 to 4 weeks. 10 or more drinks on a single occasion. So while alcohol is at historically low levels of use among teenagers, it is still a significant contributor. Then on to marijuana, cannabis. This is just about the only one when we take a look at drugs and alcohol, the psychoactive drugs. This is just about the only one that has been increasing, and it has been for several years. This is the primary driver of the measured increase in overall drug use. When we take marijuana out of the mixture, when we're measuring drug and alcohol use for youth, when we take marijuana out, the use looks different. It's either staying steady or it's even dropping in some of the measurements. But when we include marijuana in it, it props everything else up to the point that it makes it look like illicit drug use is increasing across all measurements. So recent reported increases in marijuana use have been matched by decreased perception of risk regarding marijuana. And that one is very, very timely and topical, especially today. Today we have 2 states and the District of Columbia that are looking to legalize recreational marijuana use. There's already a couple of handfuls of states that have the medical marijuana, 2 states that have recreational marijuana use, approved already, and now 2 more today that are weighing whether or not to do that. And it looks like one state probably will not, and one state very well may, and the District of Columbia is expected to overwhelmingly approve that. So when society and states say that it can be used recreationally, then certainly that is going to increase the perception that it's really not that dangerous. And I'm not going to necessarily weigh in, get up on my soapbox on recreational marijuana use is good or bad, but I will get up on the soapbox a little bit when it comes to adolescents using any kind of psychoactive substance. Like we talked about in the beginning, in those first couple of slides, with the developmental considerations, with what's going on developmentally, with the prefrontal cortex development, in measuring risk, in immediacy of reward, in all of that stuff, and stuff that is really laying down the pathways that are going to go into adulthood. Any kind of psychoactive substance use really runs very high risk. So whether or not marijuana can be used recreationally safely by adults occasionally, I don't know. Certainly there are strong opinions and learned opinions on both sides. But when it comes to adolescents using those substances, I don't think that there is any debate at all. I certainly won't entertain any debate on that. It's all on the negative side. So, but with society going in one direction, certainly our youth are saying, well, it's not that dangerous. And as that perception drops, that is always matched by an increase in actual use. And we can really take a look at some of the trends, looking back into some of those prevalence studies that support that. 45% of students reported trying marijuana at least once by their senior year of high school. So almost half of kids who have made it to their senior year in high school have tried marijuana. This one says what we just said, or this one doesn't say anything, does it? It outlines it. But it is a nice outline where you can see I'm a guy, so I really don't know what colors are. I'm going to say gold for that top color, where it's top most of the way until here in the last few years when unfortunately it falls underneath. That is the perception of risk associated with, and here we have marijuana. So you can see for most of this study, the perception of risk associated with marijuana was higher than the use of marijuana. And they really match, they mirror each other, with the blue line then being the actual prevalence of use. And you can see here as the perception of risk associated with marijuana has been falling and it continues to fall, the actual use continues to go up. So that just did a nice job of outlining that. So a little bit more about marijuana. 26% of youth reported use at least once. This is in the last year. Over the last 30 days, over 1 in 5 reported use at least once. So in the last 30 days, again, we're going to consider that current use. So 1 in 5 teenagers in the last 30 days. And then measured daily, 6% of high school seniors reported daily use of marijuana. And that one is coming from the Monitoring the Future study. And again, so that's 6% of high school seniors who showed up for school that day reported daily use of marijuana. Kind of an interesting one here, comparing cigarette use and marijuana use. And if you trace the perception of danger associated with tobacco products, that continues to increase, and tobacco products continue to decrease in use, matching that. Marijuana, on the other side, then continues to rise. So I never would have guessed this before looking at these numbers, but more teenagers smoke marijuana than smoke cigarettes. Prescription drugs, certainly one that we do want to pay quite a bit of attention to because of just the ease of getting them, the perception of safety associated with these, because if it's a prescription drug, it must be safe. And certainly we know that that is not the case. Prescription drugs, and we can include over-the-counter drugs here too, can be misused in several ways, and there can be the misperception that these types of drugs are safer. So in the last year, 15% of high school seniors reported misuse of a prescription drug. So that is obviously anytime somebody uses a drug that it is not prescribed to be used in a way that is not prescribed to be used. So it could be their own prescription that they're taking extra of, or they're taking too frequently. Could be in ways that it wasn't prescribed to use. In my experience, doctors do not recommend that you crush a pill and snort it. Getting it from others when it's not prescribed to you at all. So there's a lot of different ways to measure that. In the last 30 days, so here again we have current use. 2% of all students reported prescription drug misuse, and 7% of high school seniors reported prescription drug misuse. So current use in the last 30 days, 2% overall, 7% of the high school seniors report using a prescription drug. Really liked this one in this comparison in terms of putting 8th graders up against 12th graders in what are the most commonly used drugs. I think for a lot of you, this might be the most interesting slide in this presentation, and I should mention so far the really interesting ones are still coming up. So, 8th graders, marijuana, 12th graders, marijuana at the top of the list. And again, this is not including cigarettes and alcohol. Alcohol would certainly be at the top of that list. But as we already mentioned, marijuana then would come before cigarettes, interestingly. So when you look at the 8th graders, marijuana, king of, definitely top of the list. Inhalants being the second most commonly used psychoactive substance for 8th graders. And that drops way down when we take a look at the 12th graders. Synthetic marijuana or spice or K2, whatever, however you've heard of it. The cough medicine, and that can be both prescription and more commonly, this will be over-the-counter stuff that contains dextromethorphan. Tranquilizers, and that would be benzodiazepines, and then we get to Adderall. And then you see Oxycontin is way down on that list, and Vicodin even farther down. So that's for 8th graders. Now, when we take a look at 12th graders, marijuana up there at number 1, synthetic marijuana number 2, and this is unofficial. This is more of kind of a feedback thing from a lot of programs that we work with. The synthetics have maintained, the synthetic marijuana has maintained its popularity in large part because it is a little less likely to be tested by probation and substance use programs that test for drugs. It can be tested, it's just less likely to, so it's a little bit easier to get away with using that. Then next on that list for our 12th graders, we have Adderall, followed pretty closely by Vicodin, and then cough medicine, and then on down the list. So in terms of diverted prescriptions here, what do we have? We've got Adderall, Vicodin, cough medicine, which can be both a combination of prescription and over-the-counter, and then tranquilizers, which we don't mention specifically in here, kind of in the middle there, both for our 8th and our 12th graders, but tranquilizers predominantly being the benzodiazepines, which can be very, very dangerous used in combination with all the other drugs here, especially with alcohol, which would be at the top of both of these lists. How do kids get the prescription? This says narcotics, but this is prescription drugs. This is 12th grade, so what are the sources where they're getting their drugs? Given to them by a friend or a relative is the most common. It's just, here, I have this, and kids are impulsive, so they're more likely to try something. Or bought from a friend or a relative from their own prescription. And I think a lot of times when we see that, we think about kids with the ADHD medications, and the most commonly prescribed of those is the Adderall, and we certainly see that diverted quite a bit, so they can save it up and use it, or they can use it in a non-prescribed way by crushing it and snorting it, that sort of thing. A little bit lower down on the list, we think about kids stealing them from, the grandparents' medicine cabinet and that sort of thing, and there's a lot of public service attention out there to this now, mind your meds, where kids are going to take it. That's a little bit lower on the list. Actually, it's considerably lower on the list, but it is still a risk and one to take a good look at. So there is prevalence for drugs and alcohol, and we're going to move into mental health stuff. And I think I am going to try to stop saying so much so I can speed things up, because we are just a little bit over halfway at this point. So adolescent mental health, this coming from 2005, this should really stand out for all of us. Half of all lifetime cases of mental health issues, mental illness, begin by the age of 14, half. So very early on in the population that we are focusing on here with our teenagers, half of all lifetime cases begin by the age of 14. 3/4 have started by the age of 24. So even if we extend this on up into our transition age youth, before the brain is done with its development, 3/4 of all lifetime cases of mental illness have at least started. And I like the way National Institute of Mental Health describes this, saying that unlike heart disease and or most cancers, young people with mental disorders suffer disability when they are in the prime of their life. Another useful study to take a look at here with mental health and prevalence with kids, and this one really stands out in a couple of different ways. So this is taken from the National Comorbidity Study. This is the replication. This is the follow-up. This is the Adolescent supplement. They looked at 10,000 kids, and they did the study in a combination of going into schools and going into the homes. They included parent reports on a lot of this stuff to take a look at what the most prevalent mental health issues were and what the prevalence of comorbidity. A little bit different than co-occurrence, but they were looking to see, if you have one mental health disorder, what is the likelihood that you have another one? And that could be either on the mental health side of things, the substance abuse side of things. So when they applied DSM-IV criteria to the information that they gained from these 10,000 kids, half met criteria for some level of disorder according to the DSM-IV. So for any of you who have teenagers at home, this is probably not hard to believe, that half of all teenagers in the United States met a diagnostic threshold for a DSM-IV disorder. So does that mean that half of all of our teenagers, are mentally ill? I would certainly argue very strongly no, even if you have one at home, and would argue kind of tongue-in-cheek the other direction. But I think what this really speaks to more than anything is that working with adolescents is a specialty unto itself. We can't apply definitions that we were using just a few years ago for them when they were children, when they were school-age children. They are no longer in that category, and they are certainly not adults. But it is very easy to look at them as adults. And when we apply adult criteria to adolescents, we can identify a lot of things today that aren't necessarily there tomorrow, and then they will be back next week. It's a tough, and from my perspective, enjoyable, but it is a very difficult diagnostic age range to work with. So half of them met criteria. What does that mean? Well, not a whole lot. The next piece underneath there, nearly half of that is 22.2%, met criteria for mental disorder to an extent that they had difficulty functioning. So, here is what really stands out with mental health issues. About 1 in 5 teenagers, suffer from mental illness to the level that it is impairing. And that matches pretty well with the prevalence that we see in the adult population. It's just that here we are seeing it at the very often at the ground level, that it is really just starting to set in. What disorders do we see in teenagers? And this study really did a nice job of pulling out what is there, and it balanced it, or it presented it in a way. Here's the 50%, that they met threshold showing some of these symptoms. But when we take a look at it at the severe impairment, where really, as responsible clinicians and diagnosticians, where we would really take a look at saying, yes, this is, they have really met the threshold. Where does it stand out? So at the top of that list, and just barely, but at the top of that list, we have major depressive disorder, the mood disorders, I guess, really we could say at 8.7%, followed very closely by anxiety disorders. And it's interesting when you take a look, at the numbers above the severe impairment there, where at the overall, that it just makes sense that teenagers would show a lot of symptoms, a lot of characteristics of anxiety with everything that's going on developmentally and socially, but at the severe impairment level, considerably lower. ADHD, about 4% with severe impairment. The other behavior disorders, and with this, there can be a lot of overlap from other stuff, some unidentified stuff. We are not necessarily great big fans of or proponents of oppositional defiant disorder or conduct disorder. Just working with the co-occurring kids, just about every single co-occurring kid will meet criteria for oppositional defiant disorder, but there can be a lot of other things that drive that. So oppositional defiant disorder is useful in identifying maybe symptoms, but not necessarily useful as an overall diagnosis to describe this particular population. So when they looked at substance use disorders and alcohol, they did not break it down into overall and then severe impairment because they said that, well, they're kids. Any level of use is not okay. So they kept that as the combined. And so, the total with drug and alcohol use disorder at some level, a little over 10%. Taking a look at some other numbers with adolescent mental health, 67% of kids in Center for Substance Abuse Treatment funded programs. And what we're talking about here are ones that would be primarily substance use treatment. 67% reported experiencing victimization in their lifetime. And, we won't take the time to talk about it here today, but victimization does not necessarily mean that it's going to rise to the level that we are going to recognize it diagnostically with a PTSD diagnosis, but some level of victimization, and how much does that drive decision making, and at what point developmentally did this occur? Is it still going on? That can have a huge impact on the way decisions are made and some of the presentations. So just to keep that in mind. 13% of youth reported creating a plan for suicide in the last year. That's overall. That's not kids who are in substance use treatment. That wasn't kids who were in mental health treatment. That was 13% of all teenagers reported creating a plan for suicide in the last year. That could be a pretty vague plan. That doesn't have to be anything specific, but the next one a little bit more telling. 8% of youth reported attempting suicide in the last year. 8%. I don't even think anything needs to be added to that. Pulling these two together, and I've referenced co-occurring quite a few times, babbling on here this afternoon, and I don't think I ever really defined it, but a co-occurring disorder is when a mental health disorder and a substance use disorder are identified independently of each other and are not symptoms resulting from a single disorder. And in this, then, neither side is to be considered primary. And, this is when we talk about the integration of, identification, integration of assessments and screening instruments, and then, very importantly, of treatment protocols. Traditionally, it has been that when somebody entered, say, one side or the other, somebody entered substance use treatment, the expectation was that the substance use issues would be resolved or addressed first, and then mental health issues would be tackled, because you really couldn't flesh out what was really going on mental health-wise until the use had been considerably reduced, or even better, stopped. On the other side of things happened, that same way. If somebody was entering mental health treatment and then it was discovered that they were using drugs or alcohol, the other side, you'd say, well, you really can't address the drug or alcohol issue until, psychiatrically, some of their symptoms are more stabilized. So, we have learned through a lot of unfortunate practice that that is not the best way to do it. Certainly the best way to do it is to tackle it in an integrated fashion, say that they are both primary and they interact quite a bit, and address it that way. So 70% of youth entering substance use treatment were identified as having a co-occurring mental health disorder. This one was a great study, and in the brief on prevalence, so that would be the first brief when it comes out, it references a couple of really good studies that take a look at this, that kids who entered substance abuse treatment, and that was at all different levels, anywhere from outpatient all the way up through residential treatment, 70% were subsequently found to have a co-occurring mental health disorder. On the other side of things, then, 43% of youth receiving mental health treatment were later identified as having a co-occurring substance use disorder. People in practice sometimes will say, well, I work on the mental health side of things. I don't know anything about substance use, or I'm a substance abuse provider. I don't know anything about the mental health side of things, and I don't work with that. In truth, all of us who work with teenagers have been working with co-occurring disorders. When we take a look at the numbers, it is more likely, if we are working with a youth who has one diagnosis, that they've got something on the other side as well. So all of us who have been working with kids have been working with co-occurring kids all along. When kids get involved with the juvenile justice system, it greatly increases the likelihood that both mental health and substance use, well, both, and then thirdly, kind of a little a nod to Tom Mayatsi there, for those of you who are Car Talk fans, in the third half of our show. So both mental health, substance use, and co-occurring, all of those go up pretty dramatically when we take a look at juvenile justice involvement. It increases the risk in just all kinds of areas, including school failure, current and later unemployment, current and later criminal justice involvement, family problems, the likelihood of having both sides, the mental health, the substance use disorders. So when we look at juveniles who are in any kind of detainment, that could be anywhere from, they were sitting in detention awaiting a charge, or they were sentenced to detention, or they were sentenced to Division of Youth Services, which would be akin to kind of youth prison. So at any level, once they're in detainment, 70% have at least one mental health diagnosis of those kids. 40% have substance use disorder. And when we combine those two, 60% have a co-occurring disorder. So over half of every kid who is in detainment for any reason, over half co-occurring disorder, both sides of those issues going on. So, all right, so there are our lies, damn lies, and statistics. Why do we take the time to take a look at this stuff? Because they are so prevalent. And while the good news is a lot of the numbers are going down. Fewer kids are smoking cigarettes, fewer kids are drinking, fewer kids are binge drinking, and a lot of the numbers that we didn't talk about, they're kind of staying the same. Marijuana, on the other side, is going up, but it's important to recognize how common psychoactive substance use is in teenagers, and how common, when we see a kid on one side, on the mental health side or on the substance use side, how much we should really expect that there is more than just that one issue that they're presenting with, that there is probably more going on. So, Getting into screening and assessments, adolescents are quite difficult to accurately diagnose, which I have already rambled on about a bit. They are not yet adults, no longer children. Adolescence is the frequent starting period for both mental health and substance use disorders. That is a little bit more true about the mental health side than the substance use side. And that, mental health, over half of all lifetime cases started by the age of 14. Substance use, the over half lifetime is in the early 20s. But as soon as we have on one side, the mental health side, it increases the risk that the other side is also going to occur. So in terms of screening and assessment, then, with mental health disorders and substance use disorders, so often first manifest during adolescence. It can be thought that they are growing into the disorders. That I get from my colleague here at Center for Innovative Practices, Rick Shepler. He promotes this quite a bit, talking about when you're working with teenagers, they are growing into these disorders. They are not going to fall into, the adult diagnostic identification methods. One day they're going to look this way, and the next day they're going to look a little bit different. So they're growing into these things. Symptom and problem areas can be, and they are very easily unrecognized, hidden. Kids are even better than adults at hiding some areas of symptoms. And the symptoms themselves can be more periodic and certainly more situational than they are as they move into adulthood. So therefore, this really speaks to the importance of screenings and identified areas for assessment coming from the screenings. And they are best incorporated periodically throughout adolescent treatment. And it's important to keep that periodic assessment going, both on the mental health and the substance use side. A really important recommendation, if you are somebody who's working with kids and on the mental health side of things, if you are just seeing absolutely no progress, it does not mean that you are not doing your job clinically. It can very well mean that there is something going on that is just not recognized. And this speaks to the importance of those ongoing screenings. So this is coming from a really useful publication that came out recently from SAMHSA. This is identifying mental health and substance use problems of children and adolescents. And you can access that through SAMHSA's website. In it, it says, in mental health services, substance use screening not only should be required during diagnostic evaluation, but also should be done periodically thereafter, especially if a youth's treatment progress is slow or inconsistent. So, and that's true on both sides. If we're working on the substance use side and it is just very, very stubborn to any change, it's time to do screening to see if possibly there is something unrecognized going on, and probably even more so on the other side of things, on the mental health side of things. So in terms of looking at screening and assessment, what is screening? Screening is brief, a brief and formal process that is intended to identify signs and symptoms that indicate a need for a more in-depth assessment. So this is not the in-depth assessment itself. This is just testing the waters to see if we should take a closer look. So screening is very often the first face-to-face contact a client will have with an agency or with a provider, and it is the prime opportunity to increase the likelihood of the long or longer-term retention. This is where we want to see some of those very brief, motivationally enhancing kind of approaches that are going to increase the likelihood that they're going to come back for a second time. The tools themselves should be short and brief, and sometimes when I say that short and brief, it seems like it is it's overlapping and unnecessary, but I think it can be kept separate. That nice short screeners are great, and if they can be done very briefly, that is in a manner of just a couple of minutes, that's even better. So as long as they measure what we need them to measure. Wording should be easy for the client population to understand. The single best way to administer any kind of screener is for the clinician to administer it in person to that client, but that's not always realistic. And certainly, with the way things are paid for these days, that's just Sometimes it's just completely not realistic. With that in mind, then it can be self-administered, or a wide range of staff, not just the clinicians, are able to administer it. And with screening tools, because there's such a wide target that we can get with these, and because they are brief, they need to focus on some very specific smaller things. If we can find ones that are cheap or free, certainly that makes it a lot nicer. On the assessment side of things, when we go in more deeply then, assessment is a formal and comprehensive process to provide specific diagnostic information about the youth. This requires administration and interpretation by a licensed and trained professional. And so here, rather than it just being very brief identifying, hey, this is an area where we need to take the deeper look, this is the assistance for taking that deeper look. And at this point then, we need somebody who is trained and licensed to be able to administer this. An assessment should do several different things. First, it should help establish a formal diagnosis. It should not be. No single assessment tool should ever be used as the sole decision-making in establishing a formal diagnosis. The single best tool anybody has in making a complete assessment and coming up with a formal diagnosis is clinical experience. And if it's not just with the person doing that interview and that diagnosing, certainly you rely on supervision, you rely on consultation. So an assessment tool in and itself is not the end-all be-all, but it can be very helpful in establishing that formal diagnosis. Secondly, to evaluate the current level of need. That is, we've identified the problem area or the problem areas. And we'll keep it to a single problem area. We've come up with a diagnosis. What is the level of need? There can be different levels of need. You can be dysthymic or situationally depressed or very depressed. So there are different levels of need, for very similar areas. Determines client readiness to change. And when we're talking about youth, it's not just the client readiness to change, but if we can also include a recognition of family readiness to change, that is really going to speak to likelihood of overall involvement and a hopeful success. And then also aid in decisions about making referrals to the appropriate level of care. Now, with all of that in mind, that is across a single area of diagnosis, a single area of need. What happens when things get really complicated and you have two diagnoses or a co-occurring condition? At that point then, your assessment can help with establishing that formal diagnosis. And actually at that point then we're going to say diagnoses. And then you're going to have to evaluate the current level of need, not just for one area, but 2 or 3 or 4. And determining readiness to change can be, a big deal in that too. You can have a youth who is, let's say, I'll use it as long as I can until the DSM-5 completely takes over. My favorite Axis 1 mental health diagnosis for youth, it seems, is mood disorder NOS. And I don't feel that I am copping out with the NOS diagnosis. It's tough to really differentiate some of the very specific symptoms. So when I first meet them, a lot of times I go with that one. Let's say we have that mood disorder NOS and then cannabis dependence and alcohol abuse. So where is that kid in terms of readiness to change? Well, there's 3 separate diagnoses listed there, and it is entirely possible that the youth is fairly ready to change feeling depressed. I don't like feeling depressed. I would like to be a little bit less angry, snap at my mom a little bit less, have a little bit more motivation to get things done. I can also see that alcohol affects that, and I'm ready to talk about some changes in that. But no matter what you do not talk to me about changing my marijuana use, because that's what keeps me relaxed. God gave it to us. It grows out of the earth. You'd be happier if you smoked it. So, there we have different levels of readiness to change across different problem areas. and it gets really complicated balancing all of that. So, and then when you're balancing those different levels, then thinking about decisions and appropriate level of care, what kind of fit is there? And really that is the next level. And actually we're going to talk about that in the next webinar when it comes to matching treatment to those identified areas. What are some of the good ways to match that? And it can be difficult to find good matches for that. When you've got somebody who's ready for, the typical mental health diagnosis, not so ready for the substance use diagnosis. And then very often with that, you also have some family discord that's going on, maybe some school problems and some neighborhood problems. So there are a lot of different areas to balance with that. So, and assessments can be one useful tool in that decision making. So when we take a look at trying to differentiate screening from assessment, the line between screening and assessment, as we talked about it, should be pretty clear. Screening should be very, very brief. It should be very targeted, non-specific, just saying, take a deeper look, and then the assessment helps us take a deeper look. In reality and in practice, it's not always that easy to tell the difference between the two. Here we reference tip 42, and I don't think that we've talked about that in this series at all. TIP is Treatment Improvement Protocol. This is a very useful series produced by SAMHSA. I don't know what number they're up to now, but back on 42, this was the one that was aimed specifically for clinical work with co-occurring clients, with a co-occurring population. So part of the reference and index section in tip 42 is a nice coverage of screening and assessment tools. But unfortunately, in almost every single reference that you see, and not just from 42, but from all the sources, it's really tough to tell, hey, am I looking at a screening tool or is this an assessment tool? And sometimes the tools themselves don't really advertise which they are. It can be kind of a gray area in between. So just what to keep in mind with taking a look at screening and assessment tools. Screening instruments are brief. Typically they are easy. They shouldn't require much, if any, training. They are intended to identify a need for a more comprehensive investigation. A screening tool will never tell you that a particular diagnosis is recommended. The only thing it will tell you is that there is an identified need for a deeper look. So then on the other side, the assessment instruments, they are way more comprehensive, provide more specific diagnostic information. They can really help solidify and nail down a diagnosis. And these are going to require interpretation and probably administration by a trained and/or licensed professional. So we're going to talk about, and obviously very briefly because we just have 10 minutes left, but that's okay. We're just going to introduce two screening tools and two assessment tools. For a more comprehensive coverage of this and better recommendations for sources to use in finding and exploring these, because certainly if we covered all that could be recommended and all that was out there, this would be several series of webinars just on these tools. So we're just going to present a couple, both on the screening and the assessment side, that are pretty commonly used. And as a way of introduction, then when the briefs come out and are available, we have, I don't know, I think about 20 different recommendations for places to look to help you locate good screening tools and good assessment tools for the particular population and for the particular needs that you're looking at. So just as introduction here, a good screening tool that is very popular is the Global Appraisal of Individual Needs, the short screener. This is the GAIN SS. I bet quite a few of you are familiar with the GAIN series. If you haven't used it, certainly you've seen it referenced. The short screener, 23 scored items divided into 4 subscales. They measure internalizing and externalizing disorders, substance use, and then crime and violence. It just takes about 5 minutes, and this can be self or staff administered. It has paper and pencil versions, computer and web versions. So it's pretty versatile and it's pretty quick, but the nice thing is that it does take a look across several different areas. Internalizing, externalizing disorders. So here we have mental health, substance use, and then a social piece with the crime and violence with the justice involvement. Currently, there are English and Spanish versions available. It doesn't have to be used just as a screener, but it can also be used to measure change across the course of treatment. Little to no training is required for the administration of this, but licensing is required to get access to it. So not a lot of training involved in it, and it's pretty self-descriptive, but you do have to be licensed through the GAIN network in order to get access to it. So it's nice that this one is normed on adults and adolescents, and quite a few of the screeners and the assessment tools that are out there are not normed on adolescents. So it's nice that this one is. This one is used very specifically to screen for drug and alcohol use and the need for a deeper look here. And that's all it does is just, is evidence there that maybe we should take a deeper look here. So this is the CRAFT. This one is designed specifically for adolescents, and that's it. It wasn't started on adults and then backed up to adolescents. This one was designed specifically for adolescents. Can be self, or this one is better if it's clinician administered. It just takes a couple of minutes, and that's it. And it is in the public domain. It is absolutely free and easy to find. The name CRAFT, it's a mnemonic device with the first key letter. So C, car. Have you ever ridden in a car driven by somebody, including yourself, who was drunk or high at the time? Relax. Have you ever used drugs or alcohol to relax? Have you ever used drugs or alcohol by yourself when you're alone? Have you ever forgotten what you were doing while you were using drugs or alcohol? Has anybody in your friend group or in your family ever said to you that you should cut back or even quit using drugs or alcohol? And then the last one is, have you ever gotten into any kind of trouble while you were using either drugs or alcohol? A yes to 2 or more of those questions is the threshold then where it's recommended that you would move into an actual assessment, wondering more specifically what's going on, getting that more additional information. So very useful screener. So there's just two brief introductions to screeners. On the assessment side of things, 2 examples of assessment tools, again, not endorsing them, it's just that these are 2 that are widely recognized and used. The first one is the TASI, the Teen Addiction Severity Index. This one is a multidimensional semi-structured interview targeting adolescent substance use disorders, psychiatric disorders, and co-occurring disorders. So this one is nice in that it takes a look at both the substance use and the mental health side of things. Has subscales to measure chemical use, school status, employment and support, family relationships, peer and social relationships, juvenile justice involvement, psychiatric status. It is available in English, Spanish, and Portuguese, and there are currently more in development. This one is not in the public domain, and the difference between screening tools and assessment tools, that a lot of screening tools are in public domain, whereas a lot of the assessment tools, because they require more training and they require licensing, a lot of times they are not. But the TASI, I don't think, which is, I don't think what you're supposed to say in a training, right? You're supposed to say, I'm absolutely sure. But I don't think that they charge for it, but you do have to go through a 2-day training, and there is a fee for that. So, but it's very useful to help narrow down not just a diagnosis, but potential diagnoses, and it is also useful in terms of measuring change. Okay, and then the last one that we are going to talk about, Comprehensive Adolescent Severity Inventory, or the CASI. It's a comprehensive semi-structured, sound familiar from the last one? Semi-structured assessment and outcomes measure comprised of 10 independent modules. can be administered in 45 to 90 minutes by a trained clinician. So, here we are taking a look at a lot more specific information, a lot more information, and so, an assessment tool is going to be a lot longer than a screening tool. Modules in the CASI include health, family, stressful life events, legal status, sexual behavior, drug and alcohol use, mental health functioning, peer relationships, education, and use of free time. And it does include strength-based additions to each one of those areas. So this one is copyrighted, and there is a 2-day training required for the administration and interpretation of it. But it really helps, and both of the assessment tools that we talked about do include that co-occurring ability and piece in it. So they're very nice for that. So that is the end of the slides I have to talk about. And actually, there's 2 reference slides. If you are interested, then you can access these. So if you would like to do some more research or find out where some of this stuff came from, these were really great resources in here. I do want to follow up. There were just a couple of questions or comments, and I think what we're going to do is delay answering any of these until we get to the call-in hours, which, as I mentioned, next Monday at 2 o'clock Eastern time, and you can register at the website that Christopher listed there in the chat section for everybody to see. We can do a call-in and we can answer very specific questions. And if time runs a little bit over on that, that's fine. I will be available until you don't need me. So that's it. I thank everybody for sticking around, listening today. And I don't know, wish I had something clever to wrap up with, but I don't. So hopefully I will be able to meet some of you such that it is next Monday.